As we've already discussed, the environment for healthcare safety should really be focused on learning risk identification, analysis of risk, as well as indicators of quality, and error reduction actions being taken. Again, non-punitive error reporting should be, in a non-punitive culture, or a just culture, as we call it in North Carolina, should be the norm. As a nurse leader, we should be encouraging vigilance in identifying potential risk, and not just of ourselves, but encouraging our staff to really openly bring us problems, so that we can really stay close to those employees and know that they're going to feel good about bringing those things to us openly, so that they can be solved readily, and look for fixes and things that can fix something and do the right thing and do it right, so it stays improved and continues to improve. Creating partnerships with patients is very important, and really promoting communication about safety issues. We've talked about that before. And becoming a role model in practicing safety concepts. So it's not just walking around as a leader and saying, "Oh, you're doing that wrong." It's more, let me go in here, and if you see something that's happening as a nurse or as a nurse leader, being very gracious in terms of going into the situation, engaging, helping hand somebody something, or get into sterile garb to take care of the issue. Whatever the case is, where you can role model the best practice yourself, irregardless of what other people are doing, it's going to set the stage for, either from a peer pressure standpoint or from a leader pressure, either way, that idea that the norm in our agency and our work environment is going to be based on safety concepts being adhered to all the time. You've probably seen the term sentinel event before. This deals with a patient safety event that is not primarily related to the natural course of the patient's illness or underlying condition, that is something that does reach the patient. In addition to that, it also has to result in death, permanent harm, or severe temporary harm. So when you think about severe temporary harm, this is kind of the more outlined definition. So when you're thinking about how serious was this, and you're going to see these kinds of questions when you have to put in an event in the computerized event or incident reporting system, whether it's like the system I use at Wake, which is RL6, or other systems, they all are going to be asking and getting at, could this have been a sentinel event, by the questions that you're required to answer. And that also, in the system itself, can kind of predefine how quickly this gets submitted to someone in risk management or quality department, or gets back to your nurse leader, those kind of things. So determining whether something is a sentinel event is a huge issue. Sentinel events typically should be mandatorily reported to the Joint Commission. Some agencies do a better job at that than others, but that is the goal, is that sentinel events should be reported to them. We have also, in dealing with sentinel events, a duty to enact prevention strategies, both immediately as well as in an ongoing way, based on sentinel event alerts that come out from the Joint Commission, or based on having prevention strategies in place for all the national patient safety goals as they come out all the time. And then the overall goal of these sentinel events being utilized is based on trying to make sure that we learn, not just only within an organization, but learn throughout the whole nation through the data that's collected on sentinel events, learn from our errors and how to make improvements. You will notice that in most hospitals there's also a risk management department, and their focus is not there is quality improvement efforts in that department as well, but often, some ways you have risk management, more dealing sometimes more with legal matters, and quality improvement folks in a different department who are really looking at the ongoing management of data and indicators and quality. And risk management is more like their focus is on managing risk, financial risk to the organization due to lawsuits, preventing future losses if they become aware of a defective piece of equipment, for example. But they also have a piece in quality improvement, but often they're more the quick fixers versus the long range. And they're also responsible to kind of, once there's a high risk issue, be a first responder, come and help the departmental staff handle things properly, ensure that, evidence is maintained, different kinds of things that are very important. And they also work with whatever legal support that the hospital has should some kind of a risky situation result in a lawsuit. They do manage risk in the sense of monitoring for risk type situations and do report those, and are kind of coordinated through the quality program as well, their findings. So they deal primarily with more of incident reports, and you've seen some incident reporting systems probably in hospitals. Again, there needs to be a supportive environment for this, privacy for staff who report occurrences. Reports can be received from a broad range of personnel. It doesn't have to be the nurse that fills it out. If the nurse is not the first one, or if the nurse wasn't involved in the situation until after it was already over, it certainly can be all levels of personnel. Summaries of reports are disseminated in a timely fashion, getting back to leaders that have to be involved in further investigations. As a nurse leader, if you have an incident report on your unit, often this electronically comes to you in a way where you can review it pretty quickly via secure encrypted email. And then you can kind of already go and start your investigation fairly quick to see what the issue is. I think it's always important, besides just doing an incident report, if it is a time of day when your nurse leader is present or available in the facility, it's always a good idea to notify them personally that you're doing an incident report as well, because sometimes if they get something and they've already left the building, but they were there when this was going on, it may be serious enough they've got to turn and come back. So, please always keep that in mind. And even when they're not in the building, you're often going to be notifying a house supervisor or making sure that there is a chain of reporting up through the system to make sure that, based on severity, an action plan is getting started as soon as possible. You've probably seen the term QSIN. That deals with quality and safety education in nursing. It really is ensuring that you get some training throughout your education on all of these main tenets, so many of which is covered in this today, but you have seen threaded throughout the program as you've gone along in different kinds of classes and examples. I want to briefly finish up talking about just a little bit about outcomes research, which is in Chapter 19. Really, you have this really deals with, it can be quality data, but it also can be outcomes research that just happens to be pulled from an information system about, specific data that comes out of patient outcomes of all types. And data are usually collected about these outcomes. Trends are identified from doing some data analysis to see, is this a common occurrence, or the most common percentages, variances from a preset percentage or a data number that we feel like should be in place would be further investigated. And then if if outcomes research found that there was a specific nuance that might be causing some of these variations in outcomes for patients, then we might need to break that down and start looking at different service delivery methods. How are we really doing this process or this kind of care in a service line? To look at, is there evidence-based practice that we've not adopted that we need to? And then changes are being put in place. And then further outcomes research is done after that to see if that has had an impact on the outcomes. So these are some of the types of research that you might see. It might be called outcomes research. It might be called comparative effectiveness research, where you're looking at and comparing more than one entity on a specific effectiveness or outcome measure. And then there's some that truly is not patient outcomes, but could be outcomes of nursing care being done a certain way, or outcomes related to something related to a nurse in general. So it could be a wide range of different things that you're managing and monitoring related to outcomes in healthcare. Again, goals for outcomes research are both quality improvement, which we've already discussed, as well as risk reduction from a risk management standpoint. So when do we use this? A nurse manager might use this kind of research to determine like the optimal staff mix to achieve the best outcomes for a specific population or service line of care that they're rendering. They might try staffing one way, look at the outcomes, try doing it a different way, then look at the outcomes and then compare. They might also use this to evaluate best technologies for achieving the best outcomes for high-risk patients. So they might compare different kinds of technology and see which one gave the best outcomes. They may also, or they might look at technology over time. Is it still effective after a certain period of time? They might also use this kind of research to determine optimal organizational structures that are best in terms of how to set up and receive the best, highest patient satisfaction. They do that a lot, and in healthcare, both in ambulatory care as well as hospital care and ER care, you always are getting satisfaction surveys after the fact. And while you're giving your input and you're one person, that is all being rolled up into outcomes research to look at, why is it different ratings from, High Point to Winston-Salem if you had two different hospitals doing the same thing and the same standards. You will see in your book it talks about the mathematical model of influences, and this is just kind of like to look at what degree do these kind of different characteristics influence a quality outcome. So then you can kind of look at, is this just happening by chance, or is there really some part of this that is making this more risky on the outcomes? And then from that point, you can start to look, maybe drill down more into, is there a specific issue going on with a specific area of the population or certain area of the setting that is contributing to either positive or negative outcomes. In terms of outcome assessment, you may hear people refer to indicators, and you'll hear this in quality management also. What is an indicator of quality? These can be patient-focused measures, provider measures, or organization measures. But you typically are going to choose these indicators or variables that you think that might influence quality and put some kind of way to measure that in place. And indicators are often used to be risk adjusted to compare between groups. So for example, if you had a unit that had a huge higher percentage of elderly patients and you had a higher fall rate, then yours needs to be risk adjusted by comparison to another unit that does not have an aged population. And these are just some of the other benefits for nurse leaders to really focus on, many of which kind of talk about things we've already discussed.